Well, good afternoon. This paper was presented at the Australian Orthopaedic Association State Branch meeting in February 2020, and I acknowledge my co-author, Richard Page. I also acknowledge the Orthopaedic Association National Joint Registry staff to provide the data in this paper entitled The Anatomical Total Shoulder Arthroplasty Stems Short or Long, or maybe what about reverse? And it may be that what is best relates to the poly, and this is really an analysis of the impact of cross-linked polyethylene on stem length outcomes, and also comparing this to the reverse shoulder arthroplasty. These are my disclosures, and the directors and the staff of the Australian Orthopaedic Association National Joint Registry have nothing further to declare. So in the 2019 Joint Registry report looking at osteoarthritis of the glenohumeral joint, the summary was that the reverse shoulder arthroplasty has a lower revision rate than anatomical replacements. That if you're going to do an anatomical replacement, the short stems are performing better than long stems. And if you do an anatomical replacement, then the revision is mostly due to a rotator cuff failure. This would certainly be consistent with the enthusiasm for the increasing use of the total reverse replacement, particularly in osteoarthritis, as you can see in this rising yellow line, and the decreasing popularity of the total stemmed anatomical arthroplasty in the blue line, which is clearly falling over many years since really 2012 when the lines crossed. What's also of interest is the steady increasing line in the red line, which is the total midhead or the short stems, which it may well pass the number of total stemmed or long stem replacements in the next year or so. If I look at my own results, I find that the majority of my anatomical replacement, my osteoarthritic patients are still undergoing an anatomical replacement using a long stem, and my revision rate per 100 observed years is actually quite satisfactory compared to the other results of 1.14 revisions per 100 observed years. However, if we look at the raw data within the registry, we do find that the total stemmed replacements in green has a higher revision rate than the total reverse. So in fact, the raw data does suggest that the reverses are performing better than the anatomical. And note that in the last year or so, or at least the numbers in the registry now, there are 23,000 reverses compared to 12,000 total stemmed anatomical replacements. Note in this group, the SMR-L2 has been excluded from analysis. If we also then compare the total stemmed arthroplasty with the total reverse arthroplasty compared to the total midhead or the shorter stems, we find in fact that the total reverses are actually doing pretty nicely compared to the rest. If you're going to do an anatomical, you probably should do a midhead or a short stem. And the long stems are not doing so well compared to the other alternatives. We also know that the cross-linked polyethylene is now becoming more popular, particularly from about 2008, where there's been a steady decrease in the non-cross-linked with a steady increase in the cross-linked, but the use is now largely plateaued, so it's about half and half, if that. Still more cross-linked polyethylene. What we do know, what the registry has also shown, however, is that non-cross-linked polyethylene is not performing as well as cross-linked polyethylene, and if we see out to 10 years, there's a significant difference with a hazard ratio of about 4 times the revision rate of the non-cross-linked compared to the cross-linked. So cross-linked is doing much better in this anatomical shoulder replacement. Now, when concurrent changes are made to an arthroplastic design, an assumption is made that one of the components or changes was the primary factor in the resultant performance. As I mentioned before, in the 2019 Joint Registry report, the midhead humeral components were reported as having a lower revision rate than total stem components in anatomical total shoulder arthroplasty. However, both stem length and polyethylene type, that is cross-link versus non-cross-link, were variables in the choice of the arthroplasty, so there's a number of variables, not just the stem length. And so to determine if the polyethylene type rather than stem length was a factor, a registry ad hoc analysis was performed. All we basically did is look at the revision rate of the anatomical replacements over the period April 2004 to December 2018, and looked at total stemmed versus total midhead, or the short heads, using both types of polyethylene. That's cross-linked and non-cross-linked polyethylene. And these two variables gives us 4 potential combinations. We also looked at the revision rate over the same period for the reverse total shoulder arthroplasty. We performed a Kaplan-Meier estimate of survivorship, describing the time to first revision, and ascribed a hazard ratio from the Cox proportional hazard models, adjusting for age and gender. And these were used to compare the revision rates. What we find here is that the cross-linked polyethylene performs much better than the non-cross-linked polyethylene. What's also interesting on this graph is if we look at the midhead or the short heads, we find that both the cross-linked polyethylene and the non-cross-linked are not actually performing as well as the cross-linked long stems. And in fact, which is at this stage unexplained and there are only short-term data, the cross-linked polyethylene midheads are actually not doing particularly well at all. In fact, they're doing about as badly as the older long-term stems. So I guess watch this space. The numbers are too early, and so it's hard to provide any statistical significance, but it's it's certainly of note. So we look at this graph here, we find that the total stemmed non-cross-linked poly has a revision rate of 11.6, whereas the cross-linked polyethylene long stems has a revision rate of 4.3 at the 10-year mark. Even more interesting, if we look at if we now look at the revision rate in reverses, we find that the total stemmed cross-linked polyethylene has a revision rate of 4.3, but total reverse implants have a revision rate of 6.6, so almost 50% higher than the cross-linked polyethylene total stems. If we look at the midhead or the short heads, both are performing rather less satisfactorily than the total stem using cross-linked polyethylene. But again, early days, but watch this space, and certainly not substantially better. The other issue is what causes these anatomical replacements to fail, the long stems to fail. If we look at the overall cumulative incidence of revision in primary total stemmed replacements we find that in this main group of this 44 to 50, we find that rotator cuff insufficiency is the predominant cause, and loosening is actually a lesser cause. But in fact, we know that one particular implant, the metal back glenoid, has a much higher revision rate than the all poly glenoids, and that in this group of metal back glenoids, the predominant revision cause is cuff insufficiency. If we look at a group here where we look at the cumulative incidence of revision and we exclude the metal back glenoids, what we find that the predominant cause of failure in the anatomical replacements using all polyglenoids is in fact loosening of the glenoid, not cuff failure. So in this group of anatomical replacements that are non-metal back glenoids, we find that in fact cuff insufficiency is actually an infrequent cause of failure, and it's more likely to be loosening. And we know also from other studies, and again this is not part of this review, but we know that if you don't put the glenoid in straight, it increases the rate of loosening. And if we look at work from say Ferron and others, we find that even in 5 or 10 degrees of retroversion, the glenoid is starting to take eccentric load and only may lead to a greater rate of loosening. And so we should be getting the glenoid into nice and neutral version, and certainly anatomical and using cross-linked poly. So what are the conclusions? Well, cross-linked polyethylene performs better than non-cross-linked polyethylene. This has become very clear. The total stem plus cross-linked polyethylene produces a lower revision rate compared to shorter stems or the longer stems using conventional polyethylene. We also find that for osteoarthritis, the total stemmed anatomical shoulder replacement with cross-linked polyethylene has a lower revision rate than reverse shoulder arthroplasty. So the message is, well, we should be using cross-linked polyethylene as the hip and the knee surgeons learned many years ago. It also shows that the reverse shoulder arthroplasty actually has a higher revision rate than anatomical replacement if we're using cross-linked polyethylene in situations of osteoarthritis. The midheads have not been shown to be performing better than the more recent poly and long stems, so I guess watch this space, and it's still early days. And in reality, the reverse shoulder arthroplasty, while good for cuff arthropathy, may not be as good as anatomical shoulder arthroplasty for osteoarthritis. And in anatomical shoulder osteoarthritis, it's a loosening of the glenoid, not cuff failure, which is the main issue. So I think a rethink of the way that the numbers are going. Thank you.